be discussing on a case of a 63-year-old female who complains of shortness of breath for from 10
10 days
10
duration. 10 days
of
duration.
10 days duration, cough for 10 days duration, chest pain for 10 days, and palpitation for 10 days. All started on the same day. So, analyzing this presenting complaint, it is shortness of breath, cough, chest pain, and palpitation. So, the initial three symptoms can be attributed to either a pleural effusion associated with pleuritis, or if the shortness of breath is very severe, it can be even pneumothorax. And
we have to think that this is either a respiratory problem or a cardiovascular problem.
Yes, sir.
Okay.
Since the patient also has a palpitation, we should also suspect a cardiovascular problem. So, coming to the history of present illness, his dyspnea decreased on lying on the left side and increases on exertion, and has dry irritant cough, and has palpitation on effort, and chest pain which was central, dull, and not pleuritic. So, since his dyspnea decreased on lying on the left side, uh, it it means usually, and also it increases on exertion. Increasing on exertion mainly means that it's either a pulmonary cause or a respiratory cause.
It
and
can
dry
be anemia as well.
Yeah, anemia as well, sir. Yes. And a dry irritant cough means that usually the parenchyma is not much involved. It can be either the interstitium or the pleura. And then the palpitation on effort. It means that either it is a high volume condition causing either a mitral regurgitation or some other volume overload condition, or a arrhythmia which can be precipitated by effort. And since the chest pain is central, dull, the other differential can be pericarditis also.
So, what is the cause for dyspnea decreased on lying on left side?
It can be due to pleural effusion, sir.
Which side?
Usually, pleural effusion on the opposite side.
Which side?
Pleural effusion on the same side, sir.
Left side.
Left side. Left side.
Yes.
Yes, sir. So, coming to the past history, he has a history of diabetes mellitus and systemic hypertension for the past 15 years, and has CA cervix for past 2 years. So, and had history of radiotherapy, and while on third chemo, she developed the dyspnea. So, diabetes mellitus for 15 years and hypertension for 15 years. First of all, we have to know whether it's controlled or uncontrolled. If it is uncontrolled, there would be lots of...
Both are under control.
Under control. Okay, sir. So, and then CA cervix for 2 years and had treatment, and on third chemo developed dyspnea. So, CA cervix can either metastasize to the pleura or to the lungs, and she had radiotherapy. So, radiotherapy can induce an fibrosis of the lung, and she had chemo on the third cycle was the dyspnea. So, the chemo induced complication can be there.
What?
And it can be, the dyspnea can be chemotherapy induced also, sir. Sometimes chemotherapy, certain chemo drugs like busulfan and all causes respiratory IL, pulmonary fibrosis.
What is the indication for giving busulfan?
I actually forgot, sir.
Busulfan was a drug commonly used for CML long time back, not now.
Okay, sir.
Another
And
examination.
certain drugs like trastuzumab, then other doxorubicin, daunorubicin can also be used for, can also cause cardiac toxicity also, sir. And on examination,
we have infections overlapping a chemotherapeutic agent.
yeah.
Immunocompromised state. Okay, carry on. On
And
examination.
coming to the examination, the patient was ill looking, had dyspnea, and his pulse was 124, and the temperature was normal. So it is not proportionate to the temperature. So the patient will probably have sepsis, and respiratory rate is 25, and BP 110/70. Oh, so not so much corresponding to sepsis, and SpO2 of 85 on room air. So coming to the respiratory system examination, he has dyspnea, accessory muscles are prominent, trachea and apex pit, trachea central and apex pit not shifted, then movements decreased in bilateral basal region, stony dull and bilateral basal, so there is pleural effusion over there, left axillary, left infrascapular and interscapular area.
Okay,
and right
so
side.
What will be your differential diagnosis of bilateral dullness of lung bases? Bilaterally lung bases are dull. What is the differential diagnosis?
Pleural effusion.
Yes.
Then bilateral lower lobe pneumonia.
Okay.
Then ILD.
Yes.
Then any raised hemidiaphragm bilaterally.
Collapse of the lobes.
Collapse of the lobes.
Okay.
And then he has bilateral dull bibasal on percussion. So it means that there is pleural effusion. Auscultation, decreased breath sounds bilaterally, no adventitious sounds. And VF and VR was decreased bilaterally. So coming to the differential, so it was a case of a 63-year-old female.
No, what is the differential diagnosis?
My differentials would be a bilateral pleural effusion, sir.
Due to what?
Probably chemotherapy or malignancy induced, sir.
What are the other causes of bilateral pleural effusion?
Usually bilateral pleural effusions can be due to heart failure, nephrotic syndrome, then CLD, then severe ascites. Then
can you get bilateral pleural effusion cardiac failure?
Yes, sir. In severe heart failure, we can get bilateral pleural effusion.
What about hypothyroidism?
Yes, sir. Hypothyroidism can also cause.
What about SLE?
SLE can cause pleuritis is one of the most common.
So we have many differential diagnoses. Can you correlate it with the CA cervix?
Yes. The CA cervix can cause if locally advanced can cause bilateral HUN and can cause renal failure and then may lead to buildup of fluid in the body, can cause bilateral pleural effusion. And the chemotherapy drugs which may be given can cause the same. Then coming to the other systems, JBP was not raised. Then grade 2 systolic murmur over the cardiac basis present. Then GIT distended abdomen, no mass, shifting dullness present, seen as normal. So then 900 ml of milky white fluid drained on the left side.
What do you think?
So probably a chylothorax.
Chylothorax.
Can can also be empyema. And investigation shows an low HB, total count of 6,000 with differential of PMNL of 70%, lymphocyte of 30%. ESR was high according to our age 90, and pleural fluid 900 ml aspirated, color milky. Total count 244, lymphocyte predominant. ADA not much increased, not increased. LDH bit on the higher side.
No,
Then serum,
266.
serum.
266 and serum is 585.
Serum is 585. So not increased, sir. Not increased. More than it's more than half, 2/3. It's not. It's less than 2/3, sir. And then
But it
glucose.
is a proportion has to be 50%, no? Okay. Glucose.
Yes. And glucose is 141.
Okay.
And serum value is 150. So it favors towards a exudative according to Light's criteria.
Yes. Okay. Protein.
Protein is 3.3, where the serum is 5.2. Albumin is 1.6 and serum is 2.7. Triglyceride is on the higher side, and amylase is less than 30.
What do you think about it?
High triglyceride in pleural fluid means that it's lymph mainly. It is lymph, so it will be chylothorax. So ascitic fluid, color was milky, protein 3.4, then the serum value is 5.8, then albumin 1.7 and serum is 2.7. So low sag ascites, and so my diagnosis would be chylothorax caused due to the CA cervix and its treatment.
What about chylous ascites?
Yes, sir. Chylous ascites, probably, yeah. Chylous ascites also, sir. Diabetes mellitus, hypertension. All cases of CA cervix.
So what are the causes of chylothorax?
It can be due to trauma.
Yes.
Then
what are the different types of traumas that can produce chylothorax?
It may be in the after surgery.
Yes.
Then maybe at the neck, at the junction of where.
Like surgery is the thorax, surgery in the neck. Okay.
Sir. Then lymphoma.
Trauma. You're saying trauma, no? What are different types of traumas? Central venous catheter.
Abdominal.
Pacemaker insertion. Blunt injury. Sudden change in pressure, like sudden violent sneezing or coughing, or during delivery, all can produce rupture of the thoracic duct. What are non-traumatic causes, you know?
It can be usually due to malignancies, then certain diseases. Sir, malignancy can be due to like lymphoma, then certain other diseases like tuberculosis, sarcoidosis.
Then so second group you say is non-traumatic, and third group will be idiopathic. What are the idiopathic conditions?
Idiopathic conditions usually any involvement of the lymphatic tissue like filariasis. Lymphangioliomatosis,
lymphangioplasia.
yellow nail syndrome,
Yes, yes.
TB.
What are the compounds of yellow nail syndrome?
Yellow nails, pleural effusion, yellow nails, bronchiectasis, then and chylothorax,
Lymphedema.
lymphedema.
Yes. So trauma, non-traumatic, and idiopathic, 3 varieties are there. Okay. So
Yes, sir.
okay, differential diagnosis.
So the other differentials would be the considering the color, we can also suspect a empyema.
How do you differentiate from empyema?
Empyema, clinically the patient doesn't have any fever.
Okay.
So usually empyema presents with high fevers.
What extra physical finding will make you think it's empyema?
Severe pain, then the area between the intercostal there may be bulging.
Bulging is not commonly seen, but you may get chest wall edema.
Yes, sir. And tenderness also.
Tenderness will be there.
Yes, sir.
And so the findings are not in favor of a empyema. Any other possibility?
Then unilateral.
No. What is pseudocylothorax?
Pseudocylothorax. Pseudocylothorax. I have studied that.
When the fluid remains in the pleural cavity for a long time, and the fluid is very soft, but the sediment remains there, it looks like a chylothorax. And how do you confirm it's chylothorax?
Usually the triglyceride would be high in chylothorax, usually more than 100, 110.
And
range.
pseudo?
Then pseudo, the triglyceride would be low. Less than 50.
Will be more than 200.
Yes, sir.
And then empyema, if you can centrifuge, it becomes clear. So these are the two differential diagnoses for this color. All of them may look alike. So high cholesterol favors pseudo, and triglycerides will be low. And empyema is diagnosed by clinical and all other features. So this patient underwent investigations, and this is what you see.
So the CCT thorax dated 15 April 2024 shows a left gross and right-sided moderate pleural effusion. And USG thorax on the next day showed a left gross pleural effusion with collapsed consolidation, right mild moderate pleural effusion with underlying subsegmental lung collapse. And USG abdomen and pelvis shows a grade 1 fatty liver, mild left hydronephrosis, which may be due to the CA cervix, then moderate ascites, moderate fluid in the endometrial cavity, and also hydrometra. And pleural fluid analysis, total count was 246, lymphocyte predominant, then ADA low, LDH low, glucose high, suggesting a exudative, then albumin 1.6, protein 3.3, triglyceride high, suggestive of chylothorax, then amylase on the lower side, suggesting that it's not due to pancreatitis. Not pancreatitis. Then serum, the corresponding values were protein 5.2, albumin 2.7, LDH 585. And so the exudative lymphocyte predominant, low ADA, high triglyceride, pleural fluid was suggestive of chylothorax.
So why did you suspect pancreatitis here?
No suspicion of pancreatitis, sir. Mainly amylase was on the lower side. If amylase was higher, then would have suspected pancreatitis also.
What are the features of pleural effusion into pancreatitis?
Usually it would be unilateral pleural effusion, and the other causes of acute pancreatitis may be there.
Which side you prefer?
Acute pancreatitis mainly left side.
Other cause of left-sided pleural effusion?
Aortic dissection.
Yes.
Then heart failure.
No. Heart failure is always right side.
Right side. Yes.
To start with. Whenever somebody stretches and the lower esophagus gets torn, what that called?
Borehave syndrome.
That's right. So that produces left-side pleural effusion. What about Dressler syndrome?
Yes, sir. Dressler syndrome usually post myocardial infarction.
Okay, whatever it is. What are the differential diagnosis for left-sided pleural effusion? Since you brought out, so which side will be the pleural effusion in case of chylothorax? Right or left?
Right. Usually chylothorax, right side, sir.
It all depends upon the anatomy of the thoracic duct. You see the picture here. Thoracic duct crosses to left side and develop T5. So when you find left side chylothorax, you suspect lesion is above T5, maybe T4, 3, 2, 1 or somewhere there. And if it's right sided chylothorax, you suspect the lesion is before it crosses to the left side. So below T5. This is how you lateralize the site of the injury in case thorax, in case of chylothorax. But here is a situation where both sides are affected. So there may be multiple levels of rupture of the thoracic duct. So this localization is important.
Yes, sir.
You are right. So what is the mechanism?
So usually there will be a disruption of the duct which causes the buildup of chyle in the mediastinum, and in turn it leads to rupture of the mediastinal pleura and chylothorax formation.
So you said the pleural fluid analysis is important. You said rightly that 110 is a diagnostic one. So below 110, how do you proceed?
Below 110, then we check for the cholesterol levels.
No. If it is less than 50, no further evaluation. It excludes the diagnosis of chylothorax.
Pseudochylothorax.
And the interval between 50 and 110 is a gray zone where it needs further evaluation. So it is a situation where you can do the chylomicron analysis, electrophoresis of the chylomicron, and then you can come to conclusion it is true chylothorax or not. Then another option is make the patient have fatty food and again repeat the triglyceride measurement. What will happen then?
Then coming to the treatment, the patient had a chest tube drainage, continued drainage via the chest tube, and repeated large volume thoracocentesis should be avoided because it leads to depletion of proteins and the lymphatics, and the patient may have malnutrition and immunosuppression due to the same. So the diet which we should prescribe is a low fat, high medium chain triglyceride diet or parenteral nutrition. And medium chain triglyceride, it spares the lymphatic system through absorption via the enterocyte and directly transported to liver as free fatty acid and glycerol. And it decreases the formation of chyle and leads to resolution of the leak. It also take up around 2 weeks for chest tube output to improve.
So what exactly is the plan of treatment for this particular patient?
This particular patient had bilateral pleural chylothorax. So there will be multiple sites of lesions. So in the thoracic duct. So we should give the patient from bottom to top. We should give the patient medium chain triglyceride diet, then continuous drainage via chest tube on both sides, but no repeated volume thoracocentesis should be done. And so we should give high food with high nutritious content and allow it to resolve.
Can you do pleural disease in this patient?
If there is repeated chylothorax, we can do pleurodesis.
What is
not
the
quite sure.
usual pattern of Malignant pleural effusion.
Usually, malignant pleural effusion presents with rapid onset, hemorrhagic, recurrent pleural effusion, which doesn't resolve after multiple large volume thoracocentesis.
So that's exactly what is happening here. Okay, so actually
yes,
what we did was we just did a pleuralysis on this patient with that talcum.
Yes,
okay.
Sir.
Other medical therapies available are
Orlistat, which reduces the availability of fatty acid by reversibly inhibiting the release of lipase, and somatostatin and octreotide. It decreases the portal pressure, decreases the peristalsis and intestinal absorption of fat and triglyceride, and also decreases the lymph flow in major channels. And also, one of the most important thing is treat the underlying medical cause.
So what is Orlistat?
Orlistat actually is used to decrease fat in obese people. It decreases the absorption of fatty foods.
Is it available?
I think it's banned now, sir. It causes very steatoria, and I don't know whether it's available, sir.
It is a problem that whenever you take this drug, oil will leak through the back passage continuously. So
yes,
it is not, if people don't accept it socially, so this is not commonly prescribed. So our
yes,
final
sir.
diagnosis here is?
So our final diagnosis here is bilateral chylothorax in a patient with and CA cervix, old CA cervix on chemotherapy, all case, non-case
That's
of
okay.
diabetes.
That is the basic diagnosis of this case.
Yes, sir.
Thank you.
Welcome, sir.
എങ്ങനെയുണ്ടായിരുന്നു?